The following podcast is part of a certified educational activity titled Chasing the Itch, Exploring the BTK Inhibitor Frontier in Chronic Urticaria. Access the entire activity and complete the post-test at peerview.com/FTH860. Additional resources are also available.
Hello, this is Dr. Jonathan Bernstein from the University of Cincinnati College of Medicine. Welcome to this visual tour exploring the role of BTK inhibitors and other novel and emerging therapies for the treatment of chronic urticaria. It's important to have a good definition for urticaria. Urticaria is poorly understood and underestimated clinical condition characterized by the sudden onset of itchy wheals and/or angioedema. When we think about urticaria, a wheal has three typical features: the sharply circumscribed superficial central swelling of variable size and shape, almost invariably surrounded by reflex erythema. It also is characterized by itching and sometimes burning sensations. It's also fleeting. It's evanescent, with the skin returning to its normal appearance, usually within 30 minutes to 24 hours. Angioedema is characterized by a sudden, pronounced erythematous or skin-colored, deep swelling in the lower dermis and subcutis or mucous membrane. There's associated tingling, burning, and tightness, and sometimes pain rather than itch. And the resolution of angioedema is much slower than that of wheals. It can take up to 72 hours. We see the classification of urticaria on the basis of duration and relevance of eliciting factors. Urticaria is considered acute, meaning it lasts less than or equal to 6 weeks, or chronic, lasting longer than 6 weeks. Urticaria is classified as spontaneous, meaning there's no specific eliciting factor that's involved with its origin, or inducible, where there's a specific eliciting factor involved. For inducible hives, there are many specific triggers, the most common being symptomatic dermatographism, but also cold-induced urticaria, delayed pressure urticaria, solar and heat urticaria, vibratory angioedema, cholinergic urticaria, contact urticaria, and least common is aquagenic urticaria. Now, chronic spontaneous urticaria can have associated clinical symptoms beyond itch and swelling. Patients may complain of joint pain. They may have headache and fatigue, flushing, breathlessness, some gastrointestinal symptoms, and palpitations. What is the prevalence and duration of chronic spontaneous urticaria? Well, it's estimated that 1 to 5% of the general population will experience chronic urticaria at some point in their life. Women are twice as likely as men to have chronic spontaneous urticaria. The most common age for developing urticaria is between 30 and 50 years of age, but it can develop at any age. The duration of urticaria, again, depends on patients, whether they have angioedema or not, because if they do, they tend to experience longer lasting symptoms. However, chronic spontaneous urticaria generally lasts up to 1 to 5 years, but it can last decades. The general population presenting with hives, about 61% may have isolated hives, and about 33% of patients may have hives in association with angioedema, and 6% with only angioedema. Now, this number varies depending on population studied. There are many unmet needs in chronic spontaneous urticarias, resulting in delayed diagnosis. In fact, the average time from symptom onset to diagnosis is 2 years. Patients try to treat the disease before seeing their doctor, and symptoms may not be occurring when the patient actually visits a healthcare professional, so they may not take it seriously. There's also a complex differential diagnosis, as other conditions that manifest as hives or with hives need to be excluded. Many patients tend to be refractory to standard therapy, which includes second-generation antihistamines as first-line therapy, and omalizumab, which is a monoclonal antibody that blocks IgE antibody in the peripheral circulation and downregulates Ig receptors on mast cells, and is considered a second-line therapy for chronic spontaneous urticaria. Even at increased doses of antihistamines, the chronic spontaneous urticaria may not be well controlled. It's estimated that approximately 40 to 45% of patients will respond to antihistamines, but a similar number obviously do not. What is the workup for chronic spontaneous urticaria? And this is something that should be done in every chronic spontaneous urticaria patient. We need to confirm the diagnosis, and this means we have to formulate a differential diagnosis and rule out underlying causes, we need to try to identify a cause, looking for indicators of chronic spontaneous urticaria because of autoimmunity, either type 1 or autoimmunity type 2B. We should look at cofactors, identify potential triggers such as inducible hives, comorbidities, check again inducible hives, but also autoimmunity and maybe other psychosocial issues that could be contributing to worsening of hives. Again, what are the consequences? Identify problems with sleep, distress, sexual health, work, social performance. The component we need to assess potential biomarkers or predictors that we can discuss with patients that provide them with some anticipation how they may respond to treatments that are recommended. And what is the course? It's important to be able to talk to the patient about the natural course of this disease. And while we do this, we assess patients at baseline with validated patient-reported outcome measures, and we look at chronic spontaneous activity. We look at the impact it's having on their daily life, and we look for control over time as we start recommending different treatment regimens. This is a recommended diagnostic algorithm for chronic urticaria, and you can see that at the very top, it breaks it down to wheals and angioedema, and it goes through a series of questions that asks about recurrent unexplained fever, joint pain, malaise, which could either be autoinflammatory disease or vasculitis if the wheals are lasting longer than 24 hours. And it goes through this whole differential diagnosis. Similarly with angioedema, it excludes drugs like ACE inhibitors, tries to exclude more rare angioedema conditions like hereditary or acquired angioedema, and so forth. So I think this is something that is very useful for clinicians to determine, do patients actually have a histaminergic form of urticaria or hives induced by other mast cell mediators versus some other condition that would not respond to the treatments that we're recommending for chronic urticaria. This is the differential diagnosis of urticaria. And again, we have to rule out maculopapular cutaneous mastocytosis like urticaria pigmentosus, and certainly indolent systemic mastocytosis can present with involvement of the skin. There are now a number of mast cell activation syndromes that have been under investigation. Urticaria vasculitis, typically made by biopsy. Typically, lesions last longer than 72 hours, but in some cases, patients still may have evanescent hives and evidence of vasculitis on biopsy. Bradykinin-mediated angioedema is rare. About 1 in 50,000 people have hereditary angioedema, which is a deficiency in C1 esterase inhibitor, or the C1 esterase inhibitor is present, but it doesn't work. Exercise-induced anaphylaxis, there's a rare set of conditions called cryopyrin-associated periodic syndromes, and this includes a whole spectrum of treatments associated with cold-induced urticaria, Schnitzler syndrome, which tends to be more neutropenic on biopsy, but associated with urticaria rash and monoclonal gammopathy, Gleich syndrome, which is episodic angioedema with eosinophilia, Wells syndrome, which is granulomatous dermatitis with eosinophilic and cellulitis, and then there's other bullous diseases like bullous pemphigoid and adult onset still. So these are some of the things that we should be thinking about in the differential diagnosis. What are the recommendations for determining an underlying cause? Well, physicians should explore underlying causes by asking relevant questions to the patients with chronic urticaria, and when indicated, can order tests to confirm suspicions. However, it's not recommended to order a large number of tests because many times we don't find the underlying cause. Now, there are exceptions, and there are now emerging data that support getting a total IgE and getting an IgG anti-TPO, because these are tests that can, first of all, tell you whether someone has a type 1 or type 2B autoimmunity, and also can predict response to therapies like omalizumab. What are relevant conditions that can modify disease activity? Well, certainly if patients may have food, drug intolerances, stress, or chronic infections, and these are things that need to be looked at. And again, if they have increased disease activity associated with NSAIDs, they should avoid these treatments. If they have trouble with different foods, we need to look at whether disease activity occurs in association with foods with specific provocation or challenges in a controlled environment. And certainly we want to decrease stress, anxiety, depression, address that, because many patients tell you that they feel that when they get hives, they're very stressed. Unfortunately, treating anxiety does not prevent hives necessarily. And then chronic infections, we certainly want to rule out these conditions that could be contributing to hives. So as we've alluded to, there's a significant burden of disease associated with chronic urticaria. Patients with chronic urticaria are often embarrassed because they have these lesions all over their body and they're itching. Their patients are concerned that it's something that's infectious. There's a lot of stress and anxiety associated with this condition over time. When they feel there's no hope for treatment, there's depression, there's social isolation, sleep disturbances, and there's difficulties with school and work impairments. We refer to as absenteeism. Patients may go to work, but they're not very functional. Now, multidisciplinary care is appropriate in chronic urticaria. We certainly need to assess for other comorbid conditions, and there is a higher incidence of atopic diseases in patients with chronic urticaria. As mentioned, we want to evaluate for psychiatric and mental disorders and try to make sure those are adequately managed. And there is a higher association of autoimmune diseases in patients with chronic urticaria. So if there's suspicious symptoms consistent with thyroid disease or other autoimmune conditions, these should be evaluated and managed appropriately. And this may involve other specialists, although some of these conditions are within the bandwidth of the treating allergist, immunologist, or dermatologist. So what kind of testing should we obtain to assess chronic spontaneous urticaria? Well, we know that certain lab tests and chronic spontaneous urticaria features are linked to long disease duration, specifically at IgG anti-TPO. And we know that if patients have high CSU severity or activity at baseline, they tend to have a longer duration of disease. Parameters or biomarkers that have been linked with higher CSU activity include prothrombin fragments, D-dimers, and CRP. CRP especially, if it's elevated, may predict poor response to antihistamines. Other tests that have been linked to higher CSU activity or mean platelet volume and elevated IL-6, which are not routinely obtained per se. Other markers that are linked to poor response to treatment with second-generation antihistamines include the CRP, as I mentioned, but also the presence of concomitant chronic inducible urticaria, a positive autologous serum skin test, which is a marker for autoantibodies directed against high-affinity Ig receptors on mast cells, a high D-dimer, a high urticaria activity score, previous corticosteroid treatment, and a low basophil and eosinophil count. So these are all tests that might be useful to characterize patients further. Other markers linked to poor response to omalizumab include a low total IgE, and it's debatable whether it's less than 40 or less than 20. The positive basophil histamine releasing assay, which again is a marker for an antibody directed against Ig receptors on mast cells, history of previous immunosuppressive treatment, and low basophil Fc epsilon receptor 1 expression. And other markers that are linked to good response to cyclosporin include a low total Ig and a positive basophil histamine releasing assay. Now, when we see a patient in the office, it's important to assess disease activity at baseline and its impact on the patient as well as control. And then we want to do this serially over time to see that treatments are actually having an impact. One commonly used test is the urticaria activity score. It typically breaks down the scores into wheals and itch. If you have no wheals and no itch, then the score is 0. If you have less than 20 wheals per 24 hours and mild itch, that's a 1. If you have moderate wheals, 20 to 50 wheals per 24 hours, that's a 2 with moderate associated itching. And if you have more than 50 wheals over 24 hours, that is a score of 3 with intense severe pruritus. And so basically you add these numbers up, and the maximum score you could have is 42, which is very poorly controlled hives. And people can report this out as daily urticaria activity scores, where a score from 0 to 6, or they can do this over a week period of time where a score of 0 to 42. This is the urticaria control test, which is a very simple test that can be used in the office, and it's 4 questions, and it assesses how well their hives are controlled and what impact it's having on their daily life. So it talks about what are your physical symptoms of urticaria, what is your quality of life, how often was the treatment for your urticaria in the last 4 weeks not enough to control your hives, and then overall how how well have you had your urticaria under control in the last 4 weeks? And so the maximum disease control is 16. And basically patients with well-controlled hives have a score that's 12 or greater, and patients with poorly controlled hives have a score less than 12. The minimal response that one will want to see is improvement of 3 points. A marked response is improvement of 6 or greater points in response to treatment. So now we're going to pivot and talk about treatment options for chronic urticaria and give a closer look at the latest evidence, emerging therapeutics, and clinical applications. The basic considerations in management of chronic urticaria should include the goals of treatment, therapeutic approach, and the treatment options. And so when we think about this, we treat the patient's hives until they're completely gone. That's what our objective is. So we want to see a UAS7 of 0, which indicates complete control and normalization of quality of life. Therapeutic approaches, we certainly want to search for, and if possible, eliminate all underlying causes. We want to avoid eliciting factors such as inducible hives. We want to use pharmacologic treatment to prevent mast cell mediated release and or the effects of mast cell mediators. And in respect to treatment, as much as is needed and as little as possible. So we want to step up or step down according to the course of disease. We don't want to just keep people on high-dose treatment when they're completely controlled. Ultimately, we want to try to step down. What about management decisions and treatment adjustment? But we use this whole idea of assess, act, and adjust, and this kind of nicely summarizes it. So for the assessment, we'll get a good history. We'll look at diagnostic procedures to confirm certain conditions, such as provocation testing to confirm chronic inducible urticaria. We look at comorbidities. We try to look at severity using patient-reported outcome measures in the urticaria control test. We always want to make sure we understand patients' preferences and values when we recommend treatment. And this is what we refer to as shared decision-making. And we also want to discuss adverse effects of treatment with our patient before making these recommendations. After starting treatment, we want to modify treatment and also treat underlying comorbidities, look at non-pharmacologic interventions, especially in chronic inducible hives where they can avoid triggers, and educate the patient. And then finally adjust. We want to step up or down depending on how well controlled the patient is. And we would do this with relatively closer frequency every 2 to 4 weeks if they're not well controlled, but over time if they are well controlled and symptom-free for 3 to 6 months, start to step down. And this kind of gives you an idea with the urticaria control test, how well patients are controlled and when one might want to step up and step down based on their UCT scores. This is the algorithm from the international guidelines for treatment of chronic urticaria. And as you can see, we start with a standard dose of second-generation antihistamines, and if needed, we increase the second-generation antihistamine up to 4 times the dose. And if it's inadequate control at the high dose, after 2 to 4 weeks or earlier, and symptoms are intolerable, then we would add the second-line treatment, which would be omalizumab, if that's appropriate. Again, we talked about biomarkers that might indicate a poor response to omalizumab, so that's not a sine qua non. We also have to make sure that that's the best treatment for the specific patient that's being evaluated and managed. And then if they're not controlled on this therapy and within a 6-month period or earlier, if the symptoms are intolerable, we might add cyclosporin, which is the current third-line treatment, which is an immunosuppressant that has been shown to be effective in the treatment of chronic urticaria, but has associated toxicity and requires monitoring blood for different side effects. H1 antihistamines are the cornerstone to the pharmacotherapy for chronic spontaneous urticaria. Up to 40% of patients will respond to high-dose antihistamines or some combination of antihistamine, H1 antihistamines, and sometimes adding adjunctive therapies like H2 blockers, as well as leukotriene-modifying agents. But again, the response to antihistamines is variable. In randomized placebo-controlled trials, they demonstrated both the first and second generation H1 antihistamines reduced the major symptoms of chronic urticaria, which is itching and wheal formation and disruption of sleep and daily activities. The conclusions from these studies that non-sedating antihistamines improve quality of life for patients with chronic spontaneous urticaria. And there's many types that are listed here: cetirizine, levocetirizine, fexofenadine, loratadine, and desloratadine are the 5 second-generation antihistamines available in the United States. So as mentioned, CSU is typically treated with antihistamines, but disease remains uncontrolled for up to 50% of people living with chronic spontaneous urticaria, and there are few available treatment options. Therefore, additional safe and effective alternative treatment options are needed. So one of the later therapies in development are BTK inhibitors, and this actually illustrates the pathogenic mechanisms and therapeutic targets for chronic urticaria overall, where there's a central role for BTK suppression. And we see the different types of therapies which are targeting pathways that are important for the effector cells involved in chronic urticaria, and BTK plays an important regulatory role. These are some of the novel systemic therapies for chronic urticaria. As I mentioned, omalizumab has been approved for chronic urticaria since 2014, and it not only binds free IG, but it reduces IG receptor expression on mast cells. Dupilumab is in phase 3 trials and has been shown to improve hives. It is approved in some countries. I think it's approved in Japan, but not yet in the United States. And it targets IL-4 receptor alpha. And doing so, it inhibits both IL-4 and IL-13 cytokines, and it reduces IG levels in atopic individuals. Again, remibrutinib, rilzabrutinib are two BTK inhibitors currently not approved. Remibrutinib is in phase 3 trials, and rilzabrutinib is in phase 2 trials. Benralizumab, which targets IL-5R, is approved for the treatment of asthma, but is not approved for CSU. And the most recent phase 2 Arroyo study met with futility, so I don't think that there's a future for this treatment in the chronic urticaria. Tezepelumab, which binds TSLP, is approved for asthma, but not yet for CSU, although recent data presented at the American Academy of Allergy shows that it does have a significant effect on improving UAS scores in patients with chronic urticaria, as we know, which involve itch and hive components. Larentelimab, which is a cyclic 8 antagonist, is not approved, and the most recent studies met with futility. So currently there's interest in developing a cyclic 6 antagonist, but those studies are still not underway. And then there are anti-KIT inhibitors, which barzolvolimab is the most advanced in terms of trials. It's in phase 2, but still currently not approved. And then there's secukinumab, which binds IL-17, again approved for other conditions, but not for CSU. Also in late phase 3 trial development is dupilumab, which is a IL-4 alpha blocker that is approved for many conditions, including asthma, atopic dermatitis, eosinophilic esophagitis, prurigo nodularis, and nasal polyps. And it's being investigated in chronic spontaneous urticaria. And the name of these trials are the CUPID trials. Patients, adults and adolescents, 12 years of age and older, with a diagnosis of chronic spontaneous refractory to H1 antihistamines were enrolled. These were randomized, double-blind, parallel assignment, placebo-controlled studies. Study A included omalizumab-naive patients, whereas Study B included intolerant or incomplete responders to omalizumab. The primary endpoint was itch severity score. However, there were many other secondary endpoints in each of these studies. So phase 3 for the CUPID A study, there were 138 patients. In terms of severity, itch severity reduction, which is the primary endpoint, there was a 60% reduction with dupilumab versus 35% with standard of care. A 10.24 point reduction with dupilumab and a 6-point reduction with standard of care is the quantitative change that was observed. 65% reduction with dupilumab versus 37% with standard of care was observed for urticaria activity severity, and this was equivalent to a 20.53 point reduction for dupilumab and a 12-point reduction for standard of care. With respect to safety, the occurrence of TEAEs were generally similar between the two groups, and the most common adverse events were injection site reactions, 11% for dupilumab and 13% for placebo. Now, Study B enrolled 83 patients ages 12 to 80 years of age, and during the 24-week period, patients received dupilumab or placebo every 2 weeks added to the standard of care. However, this study did not reach statistical significance in an interim analysis despite numeric improvements observed across key endpoints. So this has led to the new CUPID C study, which is estimated to complete later this year. And again, this is evaluating the efficacy of dupilumab and CSU refractory to H1 antihistamines, very similar to study A in patients who were naive to omalizumab. There's also a LIBERTY-CSU Cupid Kids study, which is estimated to be completed in 2025, which is evaluating dupilumab and hives in children 2 years or older and less than 12 years of age. Now, remibrutinib, the REMIX 1 to REMIX 2 phase 3 studies have been presented. These were randomized placebo-controlled studies. 25 milligrams twice a day were administered compared to placebo. There were 300 patients receiving remibrutinib versus 150 receiving the placebo. All patients were on H1 antihistamine throughout the study in both arms. And then, in fact, midway through, after 24 weeks, which was the primary analysis, patients who were on placebo were shifted to remibrutinib 25 milligrams twice a day, and they were followed up on during the extension study. And the primary endpoints in scenario 1 was changed from baseline in UAS7 at week 12, and then the scenario 2 was changed from baseline in ISS7, and which is the itch severity score 7, and the hive severity score 7 at week 12. Secondary endpoints included percentage of patients with UAS7 less than or equal to 6, and UAS7 equals 0, meaning complete control at week 12, and the percentage of patients with UAS7 less than or equal to 6 at week 2. And again, occurrence of treatment emergent and serious adverse events during the study were monitored continuously. This shows the UAS7 scores from baseline in both REMIX 1 and REMIX 2, and you can see that there was a significant improvement, a significant change in UAS7 in both studies for the active drug compared to placebo, and this was statistically significant. When we look at this from change in baseline UAS7 at week 12 in both studies, we see that the actual effect was seen in both anti-IG biologically exposed as well as anti-IG biologic naive, meaning patients who had omalizumab or patients who had never had omalizumab. So there was a significant improvement compared to placebo in both studies. And the change from baseline was greater regardless of prior exposure to omalizumab, as I mentioned. Now, with respect to complete response, we see that there was a significant UAS number of patients who achieved a UAS7 of 0, 33.7 and 29.4 in the omalizumab exposed and the omalizumab naive, respectively, and similar numbers in REMIX 2 compared to placebo. Overall, the safety was very good. There was not any real quantitative differences in adverse events compared to placebo with REMIX. There was no evidence of liver toxicity in patients. There were no serious adverse events which caused patients to drop out of the study. The other oral BTK inhibitor is rilzabrutinib, and there's a current randomized, double-blind, placebo-controlled, multi-center dose-ranging phase 2 study investigating this therapy, followed by an open-label extension phase in patients with moderate to severe chronic spontaneous urticaria. That's underway, and this is in patients who use H1 antihistamine treatment but are naive to omalizumab, and some of that data is now available. So in conclusions, only up to 40 to 50% of patients with chronic hives respond to high-dose antihistamines, and therefore other treatment options are needed. Biologics have opened up the field of urticaria and provided some additional treatment options, notably omalizumab, and biologics have improved hives overall, but there's still an unmet need, and if not all patients respond to this therapy. The BTK inhibitor remibrutinib has the potential to become a novel oral treatment option that may address unmet needs of patients with CSU inadequately controlled by second-generation antihistamines. And there's now a challenge to find specific phenotypes and corresponding endotypes with point-of-care biomarkers that can lead to more targeted therapies so patients don't have to go through this long, exhaustive algorithm. And as many other biologics are in development, that may be that these treatments might be more appropriate than what we have currently available. And so we are in the age of a whole new understanding of chronic spontaneous urticaria. So this ends our discussion for today. I hope you found the activity interesting and useful to your practice. Thank you for joining me.
Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/FTH860. This activity is supported by an educational grant from Novartis Pharmaceuticals Corporation. This activity is certified by the University of Florida College of Medicine This activity is developed in collaboration with our educational partner, PVI, PeerView Institute for Medical Education. Remember to download the practice aids.